Good morning, everyone. I thank Subhashini for including me in this course, and I also thank AIOS for the opportunity. So I'm going to be talking about how to prevent and manage complications following MIGS. We all know MIGS is now very recent glaucoma surgery, which is picking up a lot, and it has served to cater all kind of glaucomas, right from mild to severe glaucomas. So why MIGS? We all know that it is a simple procedure, ab interno procedure, micro-incisional surgery, high safety profile, faster recovery and minimal trauma. Though it has a high safety profile, it does have a set of complications that one has to be aware of. So comparing the trab tube complications to the MIGS, it's very, very minimal because it doesn't have potentially blinding complications like what we saw with the previous two speakers. So how do we avoid complications following MIGS? Number one is with a good patient selection. So in order to have a good surgery outcome, a good patient selection is very, very important. Tailoring the treatment to the patient and to the type of glaucoma is also very crucial. A good detailed gonioscopic evaluation, knowledge about the angle anatomy for better visualization and skill of the surgeon, all of this play a role in the complications. So how do we prevent complications? Number one, a detailed systemic evaluation is very, very crucial in these patients who are undergoing MIGS because it is an angle-based surgery, there's a high chance of bleeding. So you have to rule out any history of any hypertension, which is uncontrolled, patient who's having cardiac illness, who's on blood thinners, blood dyscrasias, etc. So sometimes it is important also to investigate like bleeding time, clotting time, PTT before taking the patient for surgery. Stopping blood thinners is very, very crucial. Depending upon the type of blood thinner they are using, we have to titrate like whether it is for 3 days that we have to stop or 5 days or a little longer. Sometimes it's also mandatory to switch to a low dose heparin whenever needed if you cannot avoid stopping the blood thinner. And you need to have a facility of adjustable OT tables, good OVDs and use of adrenaline intraoperatively. So looking at the complications, it can be broadly classified as intraoperative and postoperative complications. The most common complication encountered is hyphema. There may be also some other subtle complications but related to the technique like DMD. There may be a false passage, there may be cyclodialysis or hydrodialysis. Postoperative complications again can be early complications or late complications. Again, postoperatively you can see a lot of patients having hyphema, retained blood clots, high intraocular pressure. Sometimes you can go for hypotony when there is cyclodialysis. Late complications like cystoid macular edema, late hypotony or persistent high intraocular pressures are also reported. So what are the risk factors for hyphema? So the type of the procedure itself. So we have procedures which include cutting of the trabecular meshwork. We have procedures which include stenting. So it could be related to the procedure itself. Then second thing is systemic history, like already what I mentioned. You have to have a good knowledge about how many days you have to stop patients from blood thinners. And younger patients, myopic patients, because of lower scleral rigidity, there is a high chance of bleeding. And also type of glaucoma that you choose to operate. Like if you use a patient, if you're going to operate on neovascular glaucoma, there may be some kind of angle neovascularization that would lead to excessive bleeding. So hyphema in MIGS surgery, it basically occurs because you're creating a direct communication between the anterior chamber and the Schlemm's canal. So there's increased outflow of aqueous and sudden changes in the pressure. So the pressure in the Schlemm's canal exceeds that of the anterior chamber. So the IOP drops below episcleral venous pressure. It pulls the blood from the Schlemm's canal and the collector channels back into the anterior chamber, causing a blood reflex, which is though it is an indicator of a successful surgery, it is a very common encounter that one would face. So this is a surgery of a MIGS surgery which is with a KDB glide instrument. You can see that it is an excisional goniectomy where we just excise the TM. So you can see that profuse bleed happens like this. So intraoperatively, it's very important to control the bleeding. First, do a thorough wash, use adrenaline to control the bleeding, use an OVD and tamponade the bleeding points, wait for some time and then resume the surgery. And later, at the end of the surgery also, whenever there is a bleeding point, you can leave some viscoelastic to tamponade the blood. And this is again another surgery which is a GAD surgery being performed here. So the initial incision you make on the TM, so this is done with an MVR blade. So once we do this, again there may be some bleeding points that you see. It is important to visualize what you're seeing. So without visualization, you may not be able to proceed with the surgical steps, number one. Secondly, you may be just having a false passage, and that might also cause more of complications like you can have hydrodialysis, you can have bleeding, cyclodialysis, etc. So compared to the other surgeries like Tenito, minimally invasive glaucoma surgery or the KDB glide, the GAT is supposed to have a lot of bleeding. bleeding, because you're basically creating a 360 degrees of trabeculotomy. So there may be bleeding points which occurs circumferentially, producing a profuse bleed. So managing hyphema, how do we avoid hyphema, or how do we control the bleed is intraoperatively. Number one is stop and displace the blood with OVDs. We can use adrenaline. You can just wait on the table, have some patience, and just give it some time to control the bleed. And then don't treat when you can't see. So whenever there is bleed, just don't proceed with the surgery. Just wait, clear out the bleed and see what is happening. Do a thorough AC wash. And so it's also okay to leave some viscoelastics, which will act as a tamponade to control the bleeding points. Post-operatively, we need to make sure that we give a tight pad and bandage, atropine. Very importantly, we'll have to restrict any activity post-operatively. Avoid Valsalva-like maneuvers, strenuous activity, and coughing or constipation should be avoided. Sometimes we can just follow the reverse Trendelenburg position as well. So early postoperative hyphemas usually are transient. They are self-limiting and they resolve within 1 to 2 weeks. And sometimes you can use steroids to speed up the resolution of the bleed. So this is a video of a patient who had a persistent hyphema for 2 weeks after surgery, and we decided to do an AC wash. So you can see that there was an organized blood clot which I'm trying to take out, but then what is important is you can see that there is fresh bleed which is coming behind. So what happens is when we resume the blood thinners, after the surgery we resume the blood thinners. So when we resume the blood thinners, there is still a tendency for them to bleed. So that is something which we also have to keep in mind, like how we can titrate this depending upon the tendency to bleed intraoperatively. So this is again another patient who had, like, after 2 weeks after the surgery, there was an organized blood clot. So I tried removing here, and then I see that there is fresh bleeds that's coming circumferentially. So I had to again inject viscoelastic, leave some viscoelastic, and then the pressure, we have to keep the closing pressure to be very, very high to avoid re-bleed, and that may cause more of high intraocular pressures post-operatively, which we have to tackle it. So this is again a patient from Andaman who had a hyphema of 3-4 millimeters, which resolved. And then again, after the hyphema resolved, in the postoperative visit when he came after 2 weeks, there was blood behind the IOL. So this is like almost half of the visual axis is covered by blood, and he was leaving to Andaman that day, so we had to actually take him for surgery and wash this. And this was a little more challenging because there was a lot of adhesions between the capsule and the IOL. So when I took for surgery, there was a lot of synechia and adhesions. So it was a little challenging to clear out all of that and go behind the IOL to do an AC wash here. So the blood is being washed under the IOL, and it appeared like there was a fresh bleed there as well. And then again I closed it with viscoelastic, both under the IOL as well as above the in the anterior chamber. So this patient did well, and he came back last week for the other eye surgery. And he decided not to go for a combined surgery because of this experience of severe bleed here. This is a post-operative picture. So there are chances of patients, after you treat the hyphema, there is a high chance of increased intraocular pressure. Number one, because we leave some viscoelastic, there may be retained blood clots, there may be post-operative inflammation, etc. And severe inflammation, because you leave viscoelastic, that may lead to a lot of fibrin membrane like what is seen here. So although we control the bleeding, we end up with another complication like a organized membrane which is sticking to the IOL, which obscures the vision. So this is very common with excessive manipulation, surgical trauma, and a prolonged surgical time, and not using steroids properly. So this is one patient who had a DM detachment during surgery. So this will float like a small membrane, which is very important to identify at the initial stage itself. Because if you just keep washing, and this may just, a total detachment is also possible there. And this is one patient post-GAT where false passage and there was an iridodialysis. And sometimes wrong identification, you may just end up with cyclodialysis, and post-operatively the patient will have hypotony. So all of this can happen. This is one particular patient who's a JOAG patient who's an architect. He had a family history of glaucoma, so I operated on him, and then he had diffuse hyphema. So we went and washed the hyphema, and after that his pupil became fixed like this. He developed a cataract. So it was actually bothering his vision. So he came just for a surgery, and he ended up doing 3 surgeries, one AC wash, and then we also had to take up for cataract surgery following this. So there are also problems related to the device because eye stent, though I'm not using very commonly, it is still possible to get stent occlusions or migrations or displacement, which is dealt with. And reviewing the literature that looking at the complications, the GAT complications, or any complication for that matter with any of the MIGS, most common complication is hyphema. Whether it is with GAT or KDB, it's mostly with hyphema. So the takeaway pearls here are choosing the right mix based on the severity of the disease. The angle status and type of glaucoma is very important. Careful gonioscopy and adequate surgical training is essential to avoid complications. Stopping blood thinners and taking adequate measures to control intraoperative bleed is important. Close postoperative monitoring is necessary to identify the complications and prompt management, especially when you have to restart them on blood thinners. I generally follow the 4P rule, basically practice, patience, perseverance, and prayers can all help in managing complications. Thank you for patient hearing.
Thank you, Dr. Sharmila, for highlighting the possible complications of the mixed surgeries, and it's very important to be aware of these and to manage these complications.